एक second. Okay. Okay. Thank you.
Usual, I'm traveling.
Okay, sir. Okay, sir.
मैं कार में हूँ. Whenever you will say, then I'll stop the car on one side and say, and then.
Okay, sir. I mean, shall we start? Whatever you, because without your permission, I cannot.
No, 8:30 is just now. You can wait for 5 minutes for people to join. Your panelists should join. No, your all panelists. Because सबको बोलो join करने के लिए. Unless they join, you will start the program. कैसे होगा?
Yes, sir. Yes. Yes, sir. Yes. We will start in just a moment. Our panelists are joining just now, so we will start in just maybe another couple of minutes. Before we start, I just thank all the people who agreed to be a part of this program. Is my sound coming? Hello.
Yes, so we can hear you.
Okay, thank you. So at the onset, I would like to thank Dr. Nirmal Surya, who has been always a pillar behind all innovative works in neurology and since he has taken over the president of IAN. He has been doing very innovative things, and has been encouraging us to go for awareness, go for between public and neurologist interface, these kind of things. It's a very important thing, because awareness is the most important thing when we talk of diseases of neurology. Uh, also like to thank uh, Shri Sunil Barnawal, who is Joint Secretary, Ministry of Home Affairs, who also consented to give his valuable time uh, on this occasion, and to speak few words about awareness, the importance of public health uh, and epilepsy. And also my mentor, Professor Gautam Ganguly, who is the head of Department of Neurology in Bangalore Institute of Neurosciences, which is considered to be Makkah of neurology in Eastern India. We have also Sri Narayan Rai, who is a eminent person of Ranchi. He is a ex-Chief Justice, and who has joined with us. We have also Dr. Professor Chitranjan Rai, who is a professor of community medicine, ex-dean of Darbhanga Medical College, and Dr. Surender Kumar, who is associate professor neurology, my dear friend, and also Dr. Shawmai Darshan Nayak, who is associate professor and HOD of Department of Neurology at Berhampur. We have also with us Sri Dipankar Chaudhary, who is a young IS officer, and we want young people to understand about this epilepsy, so that in future the programs regarding in relation to epilepsy and epilepsy awareness should be taken by government also. And apart from that, people are joining. Dr. MN Singh, who is an eminent neurologist in Jamshedpur, senior neurologist, he has also joined. Thank you, sir, for coming. And we have also Dr. Kumar Vijay Anand, who is a consultant neurologist at Medanta Hospital. I think at the onset, I would like to invite Dr. Nirmal Surya to say a few words of encouragement to our team and bless us. Sir, can we give the mic to Dr. Nirmal Surya, please?
Right. So, good evening, friends. I just finished one program of, in fact, from morning we had repeated programs, and I just finished Dimag Pe Charcha, the one show which is a live show which I've been doing. So that's the reason I'm traveling in the car, and I have stopped at Pada Road, right opposite the Lata Mangeshkar's house. Few days ago, Lata Mangeshkar expired last Sunday, so I'm just back opposite Lata Mangeshkar's house. So it's given me a great pleasure to announce that today's International Epilepsy Day celebrated across the country, and what best that this day is fallen on Valentine Day, and the theme for today is love a person with epilepsy. So I have requested Dr. Roy to take this project, create awareness in Eastern India, and he has really done this wonderfully well. I'm absolutely glad that we had today various part of the country doing the awareness on epilepsy. As you people all know that there are 50 million people suffering with epilepsy in worldwide, and India has 1.2 million people suffering from epilepsy. The treatment gap for epilepsy, particularly in rural area, is 75%. And unless we create a real awareness program for people to know that what epilepsy is, and let them know that 75 to 70 to 75% patient can be treated with single drug if they take it regularly, and then remove those myths and taboo with epilepsy. ऊपरी हवा लग गई है, भूत प्रेत आ गया है, उसने नजर लगा दी है. All that myths has to be removed, and I think this sort of a public awareness program where expert in neurology are going to speak to the patient, tell them that this is what they can do. If you have an epileptic attack, straight away go to the neurologist, get yourself investigated, find out what the problem is, and get the early treatment so that you can become better. I wish best wishes to Dr. Ra and Ujjwal. This is not going to be the first program. I'm sure in future also you will create awareness on various neurological disorders, particularly in Eastern India, with the help of other colleagues from Odisha, Bengal, and other part of the Eastern India. So with that note, I thank you very much for inviting me to inaugurate the this program, and I'm very happy, and I'm sure it will be most successful program today. Thank you very much.
Thank you, sir. Thank you for your blessings. And you have been encouraging all of us since you have taken as a president of Indian Academy of Neurology. Uh, Without wasting time, I think we should start our sessions. Our uh, so can I share my screen? I will just talk for around maybe 5 to 10 minutes. That's all, because many people are there who are not experts here, who are who are a part of policy making. You are the part of some few patients are also there here. So just a few words of that why we need awareness. Can I share my screen? Just one moment.
You go on to the screen share,
Yeah,
and
yeah,
click on that.
yeah. I've already done that.
Yeah.
Is my screen coming here or not?
Yes, sir. We are getting that. Yeah.
Yeah. So why do we need epilepsy awareness? So so the main important thing is that anyone can have epilepsy. So this is just a diagram, a photo made by a patient, a child suffering with epilepsy. So for people who are who do not know, or are like who are not aware of what epilepsy is, so epilepsy is just a common chronic neurological disorder which are characterized by unprovoked seizures. So we also call seizures as fits or convulsions. So it is basically the chemical balance in the brain which becomes upset, and there is abnormal firing of the nerve cell. Now, one seizure does not constitute epilepsy. When we talk of epilepsy, today only one patient asked me that, sir, what is the difference between epilepsy and seizure? So I have seizure or epilepsy? So it's like one seizure doesn't constitute of epilepsy. So epilepsy is a syndrome basically. I'm not going to technical details, just for common thing that epilepsy and seizure are actually interchangeably, used when we talk of common people and all. But yes, technically it's not one and the same. So as I said, the seizure is a burst of electrical activity in the brain. Now that is basically so the brain is like so left side of the brain controls the right side, the basic thing that we all know, and the right side controls the left. So there are different areas in the brain. So suppose there is some motor area. So there is one area for the hand movement. So if there is some problem in that area, some electrical discharge, abnormal electrical discharge, so we will have problems in hand movement. There may be repetitive hand movement, something like that, and there is some disruption of the pathways. So that results into these kind of problems. And seizure actually, as I said, it's a normal, self-limiting discharge from a group of neurons. So if it's the neurons which constitute of hand movement or speech, so there may be problem in speech or hand movement. So it's a common serious condition. Approximately 40 different types of seizures are there, can develop at any age. That's very important. And as I showed in the first figure, that picture, and mostly it's diagnosed before age of 20, but yes, it can appear at at any age. We do often see late onset seizures at 50, 60, something like that. And the important thing is that never assume that all seizures are epileptic in nature. So that is also very important. I'm not going to details of this, but yes, What is important, why this line is there, is because you should always consult an expert neurologist. That's what. And what causes epilepsy? So there are some known causes like birth injury, head injury, stroke, brain hemorrhage, brain tumor, meningitis, drugs, alcohol. Genetic. Now that's a very wide. So idiopathic epilepsy, as we say, the cause is not known. So now the 60% of 60 to 70% cases, the cause is unknown. So then we call it as a idiopathic epilepsy. But now the consensus is that all idiopathic epilepsies, they are actually genetic epilepsies. So when we call of idiopathic generalized epilepsy, so it's like genetic epilepsy. So because it's very difficult to trace these kind of genes, because it's not that simple Mendelian inheritance where we just trace a gene and then just tell that yes, this is the gene for Huntington's disease, this is the CAG repeat. Some not like that. It's a like very vast kind of thing, very polygenic inheritance. So it becomes sometimes difficult. So when we talk of idiopathic epilepsy, the people ask me that what is the cause of the epilepsy. So I explain them, see, this is idiopathic epilepsy, although it's now the consensus is that all idiopathic epilepsy are mostly genetic. And there is no single test. That's very important. So some person comes to me and tells that EEG is normal. So does it, do I have epilepsy? Yes, you may have, because when you have that seizure, if you record a EEG at that time, that's most important. And so most important is the medical history. So all patients, I really, sometimes what happens, as we all neurologists, we all know, but I'm telling it for the common people out here and other distinguished guests. So when we say that it's epilepsy, so then we have to really document that yes, when we are having these kind of movements, EEG has to be abnormal. So we sometimes we tell the patients, we encourage the patients to video record it. When we video record it, then only it's we can understand that yes, this is epileptic seizure only. Sometimes other things also mimic seizure. So it's very important to video record those events. And as we know, EEG, MRI, blood and genetic testings is important. And EEG test, as we know, treatment, anti-epileptic drugs, everyone knows, and other therapies like ketogenic diet, vagus nerve stimulation, and surgery. So these are, where the seizures are refractory. I'm not going into those technical details here because it's a awareness. And what are the very important for the patients, especially what are the potential triggers? So missed or late medication. So you cannot miss the medication. Even you cannot, just do some, some like alteration in time when you take these medications. Like if you have to take it at you have a routine of taking that medication at 9 p.m. It should not be 10 or 10:30. That is what the big dictum is. And obviously the lack of sleep, tiredness, stress, excitement, high temperature, menstruation, puberty, alcohol. Alcohol is very important here because sometimes these patients have alcohol and then they drive and simultaneously they have seizures. Because so in epilepsy, if you are taking an alcohol, that's like, I mean, it's a it's a very bad thing. And just basically whenever like these are things which actually stress out the neuron. So whenever the neuron is stressed, you can have precipitate the epilepsy. So I'll just rush because we have less time. So 20 to 30%, the excellent prognosis there, seizure free after anti-epileptic withdrawal. So that's very important. Patients ask me that sir, we will क्या इसको हम दवा को हटा सकते हैं, दवा को छुड़ा सकते हैं कि नहीं? So answer is 20 to 30%. So 20 to 30% cases we can withdraw these drugs, and 20 to 30% a good prognosis, because when we take anti-epileptic drugs, there is remission. They do not have these recurrent epilepsies. But yes, these are 30 to 40% patients do have seizures continuous despite treatment. And anti-epileptic drugs may only reduce frequency or severity. And classification of seizure, as we know, generalized seizures and focal seizures. So generalized seizure is like something when these patients ask me that generalized seizure or partial seizure क्या चीज है सर, आप बताएं. तो मैं आई एक्सप्लेन them कि देखिए जनरलाइज सीजर जहां ब्रेन में पूरे आग लग गया, अगर एक पर्टिकुलर एरिया में आग लगी है, that means if there is some focal area which has involved in this seizure, so it's a focal seizure. Suppose if there is speech areas, then patient may have vocalization, that something like something like that. So if there is a involvement of some hand area, then patient may have hand movement, something like that. If the patient has sensory area, so the patient may have sensory seizures also. So that's a focal seizure. But generalized seizure, like the whole brain is activated, and there is tonic-clonic movements and something like that. Not only tonic-clonic, sometimes generalized seizure also, absence epilepsy is also generalized seizure. So but just for the common person, a generalized seizure mostly it's like tonic-clonic seizures, and where the whole brain is like activated, like sometimes something like aag lag gayi pure brain, something like that. I explained the patient like that. And then there is bowel and urinary incontinence is there. These are just representations. I'm rushing through these slides. I've already explained these. So this is a very important slide. I just take just 2 minutes. So what are the things that we should do? So you should keep calm, guide the person from danger, stay with the person until fully recovered. So these are the first is aids. So once you see a patient with seizure, so what you should do? So the most important thing is that keep calm, guide the person from danger. Like if he's like on stairs, you just hold him or her and stay with the person until fully recovered. Talk quietly to reassure them, the patients and patient relatives also, and repeat. Suppose they have missed any dose, so they have to repeat the dose, and obviously record the time and length. If possible, we can record by video if like sometimes, but yes, it's very difficult to say that some patient has seizures, so you start recording. So yes, it's not practical possible, but yes, if the patients know that yes, sometimes we have to document this when we meet to the doctor, because sometimes it's very difficult to precipitate this seizure. Sometimes we do sleep deprivation, all these kind of things. So video is very important. What's important is what we should not do. So we should not restrain the person, act in a way that could abrupt movements or shout. Assume the person is aware what is happening, attempt to bring the person around, and we should not put like juta suhana and putting some spoons. Those kind of things should not be done. Just so I'll just rush on these slides. So generalized seizures already I've explained. I'm not going to. These are yeah. So recovery. This is the recovery position that we should do. So lateral, we should do it, and and this is the actual posture. So I'm not going to. This picture is self-explanatory. So we should always call ambulance. That's very important. Inhaled midazolam can be given. Just one slide more. Emergency medication. So epilepsy and risk assessment. This has to be done by the primary care. Now this last slide. So stigma and quality of life. So what's important is that there is a stigma and quality of life. That's impaired. So stigma is there, and so risks of injury and fractures are there. So these are the risks with epilepsy and medication side effects. And there is one very important thing: sudden unexpected death in epilepsy. So that's also a thing which happens with some individuals. I'm not going to detail of this SUDEP, but yes, SUDEP is very important thing. And who are at risk of SUDEP? So this is very important. So nocturnal seizures who are young adults, and medication compliance is less, and lifestyle issue like alcohol. And so it's as I said, alcohol is a big no with the patient with a seizure. So these are the practical safety tips everyone should know, that ensure family members and colleagues know about your epilepsy and first aid care. Whenever you are working in office, you should know. And sometimes you should keep a sometimes in the United States, on the iCard, on all those things, it's written that yes, the patient has epilepsy. So you should attend all epilepsy appointments with the doctor or nurse, and take prescribed medication as directed. Shower rather than bath. Inform people of your scheduled routine. We are medic alert. And as I said, information should be. Now the thing is that just this is my last slide. There are many fears and myths. So this whole session is about fears and myths. So there are lots and lots of myths about epilepsy, and there is this due to lack of knowledge. Special mention is women with epilepsy. What is the concern? The concern is that, so Dr. Soumya will cover it in detail, but just one line: the marriage concern is very important concern. When we talk of epilepsy, people come to us with these kind of problems with conception, fear of some problems. Fear is very important. But so we have to counsel the patient. We have to make them understand, make the patient and as well as family understand what's the problem, what up to what extent the problem can go, and what is the solution. And the stigma in the society, as I said, and children and adults should be encouraged to actively participate. We have been doing these kind of activities in past, and as you can see, we had joint hand with Jharkhand police at some time back, 2 years back, and with the traffic SP also he had cooperated, and he is there in the photo. So we marched around 5-6 kilometers, and then we did some Nukkar Natak, these kind of things. And we have been doing awareness programs also out here in Jharkhand. So and Dr. Nirmal Surya has been guiding me since many years. And obviously Dr. Gautam Ganguly, Professor Gautam Ganguly, these are my guardians here. So they have been guided. I think I will finish here, and I'd also like to invite the next speaker, Shri Sunil Barnawal, who has been always keen in understanding and uh, uh, talking about medical. He's very interested in medical field, and always tries to understand the problems of common people, his family, other people, like He's such a helping attitude. So I thought he should be definitely be a part of it, because he has been always interested in this thing. Uh, can I have Sunil sir? Bhavesh, can we hand over to him?
Yes. So can you hear me now?
Yes, sir, we can.
Yes, sir. Yes, sir.
Yes.
Yes, sir. Yes.
So thank you, Ujjwal, and thanks to this Indian Academy of Neurology. It's indeed a great, occasion for attending this program, and that too, I could know that today is the International Epilepsy Day. Though we have been hearing about the epilepsy right from our childhood days, and this is part of our social cultural issues also, and everyone in the society or the community views this as a very different kind of problem. It is more with the research, medical studies, and all. So many things have been established, and so many things have been disproved, and that is what need to be brought to the knowledge of people in the society, that what they believe is not the truth, and what they need to believe is what the truth is. So this is not just a medical problem. This is more of a social problem, more of a psychological problem, and this need to be tackled also in the that way, or a multi-pronged strategy, where besides the treatment, the challenges other than the treatment which exist in the society need to be addressed. And the challenges are what has been told by the both the speakers, that there are a lot of myth in the society. There is a lot of preconceived notion about this disease, and because of this lot of overreaction to this issue, there has been more damage to the society, to the individual, to the families, and more social problem has been caused. It is more so with the population which is vulnerable, especially the women, many old age women, many young girls, and many people who are actually supposed to be caregiver to the patient, are affected by this issue. So what I realized, this problem, though maybe if we see medically, might be should have the same percentage of the population suffering epilepsy, whereas the economic cost of this problem is much higher in the poorer societies, and that is why it has become a bigger challenge. Though I believe the percentage of epilepsy patient would be same in a say richer societies or a better off societies, but the challenge becomes much more in the where the societies are away from the
Sir, can you put your mic closely, because it is not just one mic.
yeah, I worked in Jharkhand, and And see, I was just going through some of the information. Jharkhand is one of the states where the treatment gap is very high. And the treatment gap being very high automatically puts huge pressure on the society. And the society as such views this more from the social point of view, more from a community, and also the individual, maybe a lot of myths and perception about this problem. So this need to be addressed more as a public health problem than just a treatment problem. Though our doctor friends, they are addressing the treatment gaps which exist in the society, but we as the administrator, persons working in the public policy domain, need to address this more from the public health point of view. And that is that is where our success to address this problem also lies. We have all seen that many of the problems gets disproportionately high proportion of economic cost when it becomes a social problem. See, in case of COVID itself, you see, if we treat simply like a disease, it is just an individual problem. But when it becomes a problem for the society, our reactions to the society to the problem, or denying access to the for the treatment, these all becomes a much bigger public health problem. And that is what I see is the problem in case of epilepsy. and uh, and challenges are more with the poorer society and where the resources are less. So the biggest approach is what we need to do is to create awareness and use all possible means to make people aware right from the beginning. Probably we need to start talking about in the families and the societies that this is a disease which can be cured, which can be addressed, which can be handled, and without compromising on quality of life. And if that gets conveyed, probably many of us will be viewing this problem very differently, and we can solve to a large extent many of the losses which the wrong perception of this disease has created in the society. I'm sure that governments should take note of this. What the doctors are prescribing are based on their treatment results, and also the way patients come with the problems. Their prescription and our understanding of the social repercussions will solve this problem to a large extent. I'm very thankful that today this webinar is being organized, and this is in a way will go long way in creating awareness more so for the people who are not so much aware about the disease part of this. And for me, in fact, the presentation itself was giving a lot of information which otherwise we also as an administrator may not be knowing it. So this is a good initiative. And Dr. Ujjwal, who is working in Jharkhand and who understands the demography of Jharkhand very well, and also the nature of society there, I think this kind of conference meeting or webinar will help creating a lot of awareness among the society. So once again, thank you for inviting me to this and giving me per se alternative perspective to handle this issue in the society. Thank you.
Thank you very much, sir. Thank you for your valuable time. Actually, when I was thinking that whom in public health, like public health and policy making part, I was talking with sir. So I said that there is one person I know who is a very senior IS officer, but has lots and lots of interest in medical science and medical science related things. So he's always so much inquisitive about things, and he wants to serve the people around him, not only family but friends, everyone. So I thought you would be the best person. Thanks a lot, sir. I cannot thank you. I do not have words to thank you, sir. Thank you very much.
Thank you.
Sir. So with that, our next speaker would be Dr. Shawmai Darshan Nayak. He's a very eminent neurologist from Odisha, and he is associate professor in Behrampur, and he has lots and lots of academic interest, papers, and lots and lots of talks all over, national and international talks he has given. And I will not waste time. I cannot talk about him. That actually is so please, Soumya, please carry on.
Thank you, Ujjwal. Thank you for giving us this wonderful platform on this wonderful day. Coincidentally, as Sir said, that Valentine's Day and International Epilepsy Day, they have coincided. So the theme being love a person with epilepsy. So what better day can we get to highlight this noble cause? And thank you for the vast number of speakers, panelists, eminent panelists you have called upon, especially policymakers, Sujit sir. So we are very thankful they have given time for hearing us, hearing for a cause. As we are all social neurologists, we have not only duty as doctors, but also as teachers, as administrators, and also have duty towards the general public in creating awareness. So with this, I start my topic, women with epilepsy. I thank Ujjwal for entrusting me. I hope my screen is visible. So this topic
Yes,
is
it's visible.
very
Yes, please.
close to our heart. We know women as Durga, as Lakshmi, as Saraswati, but a woman with epilepsy is always looked down upon. There are so many social stigma associated with epilepsy. Nirmal sir has been the backbone of epilepsy awareness in India, and he has always encouraged us to propagate, teach, make aware people with epilepsy, the myths, the reality, and the treatability of epilepsy. But being a woman with epilepsy is not being a man with epilepsy. A woman cannot stand up and disclose that I have epilepsy. It's very difficult for a woman to express that she suffers from epilepsy. This has been an integral part of society that we hide the symptoms of epilepsy right from the beginning. We do not treat girl child with epilepsy. We think of her as a burden on the family till marriage. Even after marriage, the atrocities on women does not end. They are subjected to violence even at the sasural level, even their in-laws, their husbands, they are looked down upon. She's not accepted back into her parent family. She has nowhere to go once her in-laws find out that she has epilepsy. Parents, to save their daughters, give drugs in vitamin pills. With vitamin bottles, they give anti-epileptic drugs. This is the bare thing which we see in villages. 70% people believe that these women have been possessed by evil spirits, and they are branded with iron rods and the neck. I have seen on the abdomen, I have seen on the hands, on the back. So think of the situation, the so much of trouble which a child has to go, a girl child especially, when she's diagnosed with epilepsy. There are various examples where we have courageous women who have fought and won. So we provide these examples to our ladies, to our girls, to our sisters, to our mothers, to encourage them that you have to stand up and fight, because bold is beautiful. You have to openly come up. You have to say, yes, I have the disease, but I have the courage to fight. Starting from age old, there are Aristotle, Napoleon, Julius Caesar, Agatha Christie, to many actresses who had epilepsy in the past but did not reveal, to the present day actresses who now come up openly, like Shefali Zariwala. She openly said, I have epilepsy and I stand against it, I'll fight against it. So, my dear friends, the need of the hour is not only creating awareness but giving courage to our women folk that yes, you can stand up and fight against the disease. There's nothing to hide. What more than seeing a seizing girl in our emergency if we cannot manage her properly? So, not only do we have to train our doctors, as Dr. Ujjwal has rightly pointed out, that to identify a focal epilepsy, to identify a generalized epilepsy, to identify a status. So these things have to be taught not only to our MBBS level doctors to improve or enhance the mechanism of treatment, but also to give courage to the people that yes, this is a treatable condition. So there are a lot of things that go beyond seizure control, starting from the time a girl starts menstruating, catamenial epilepsy, marriage. Marriage is a big proposition, as Dr. Ujjwal has rightly pointed out. Pregnancy, having a child, family planning, breastfeeding, menopause, all these are very, very important issues in a woman's life. Catamenial or catamenios means monthly seizures. Usually these occur during menstruation, and the child, once she starts seizing or a woman starts seizing, she's very much perplexed, anxious, and what is required is not only reassure but also identifying the condition and also treating it so that there are no taboos associated with catamenios. Very commonly, these women with epilepsy have reproductive dysfunction, they are obese, they become hirsute, that is, they develop facial hairs, there is infertility, menstrual irregularities in as many as 12 to 14% of the women. If you remember, Nirmal sir had said 1.2 million women are of the reproductive age group. And once these women are treated with drugs, they have body dysmorphism. Some gain weight and develop hirsutism. Some have no gain, some lose weight. So it is very important for doctors to know which drugs to use for which women. Diet forms an important part in teaching women what to consume, what not to consume, starting from low amount of carbohydrate to diets high in protein and fat. Most importantly, once a child grows to marriage age, now 21, it is very perplexing for parents whether to reveal or disclose, or to conceal. So it is very difficult because once you reveal that a girl child is epileptic, it becomes very difficult to find a match for the girl. And even if you hide and marry off your daughter, once the in-laws find she's seizing, it becomes very difficult to make them understand, and these lead to broken marriages, lot of torture on the girl child, physical abuse, and whatnot. So this article reviewed that whether you should disclose or conceal, it is very important that the girl has a one-to-one talk with her would-be, reveals to him first rather than the in-laws. If the boy is accepting her with her condition, then nothing more than that. There are issues with pregnancy. Fertility is an issue. Which drug should be taken is an issue. Most women, who, once they find they are pregnant, they stop drugs. That is dangerous. So, what will happen to seizure control? There are a lot of questions during pregnancy. So, these issues are usually that women with epilepsy are unable to stop drugs. Once they stop drugs, seizure increases, there's lot of miscarriage, developmental delay, cognitive decline in the fetus, and complications of pregnancy and labor. Risk of congenital malformations are increased. Now, if they, they don't stop the drug, they go on taking drugs, that is also a problem, because some drugs are suitable, the others are not. So this should be made aware, especially to the gynecologists and to the treating doctors who have patients with pregnancy, that those drugs which are safe should be given to women once they start planning pregnancy. And folate supplementation is a must. So drugs which are contraindicated in pregnancy like valproate, carbamazepine, phenytoin, older generation drugs like phenobarbital should be gradually withdrawn, and safer drugs like lev or lamotrigine should be given. Delivery is also a problem, and proper consultation of the doctor should be done lest the patient develops complications. We should be very careful about the fetus also, because sometimes the fetus develops risks in pregnancy. So seizure control should be maximal. Remember, 30% of women have decreased seizures, while 20 to 25% have no change, while 40 to 50% have an increase in their seizure risk. A breastfeeding mother is also anxious. She wants to know whether breastfeeding should be done or not. Just assure her that breastfeeding is not contraindicated. She should be breastfeeding her baby. Breast milk contains lot of vitamins and minerals which
Dr. Soumya, we are not getting your voice. Dr. Soumya, we are not getting your voice. Kindly. Yes. Bhavesh, can you check what is happening? Why we are not getting his voice?
Yes, sir, I just checked that.
Bhavesh, am I audible now?
Yes, you are.
Yes,
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 you
you
are.
are.
Yeah.
Okay. So those planning for family planning should be taking safer anti-epileptics like levetiracetam or valproate or benzodiazepines or gabapentin, but not the older generation drugs or enzyme inducers. So, last but not the least, the take home message is always female patients should talk to their doctors regarding marriage, pregnancy, contraception. Pregnancy, we should encourage uh, proper treatment, proper access to doctors. As you know, that neurologists are rare, so you have to go to the primary care physician. It is more imperative that we treat, we not only teach doctors at the grassroots level, but also obstetricians how to manage such cases. Folate, calcium, and vitamin D supplementation is necessary for all. Vitamin K is also important for pregnant women. Last but not the least, we, in our own way, small ways, we should try to propagate awareness about epilepsy, remove all the myths. For that, we take up the print media, the social media, including encouraging NGOs and also involving people from out of the medical fraternity. And I'm thankful that Dr. Nirmal Surya has been the backbone of epilepsy awareness in India, especially in Eastern India, where there is a very less awareness about epilepsy. We should take courage from people or celebrities who have epilepsy and who have fought and won, like John T. Rhodes. So I thank you all for this patient hearing, and I'll be ready for any questions also. Thank you, Ujjwal, for this platform.
That was indeed a wonderful talk. You have covered most aspects regarding this. We'd like to mention here that Indian Academy of Neurology has been working on this that marital thing, na. So in Chandigarh, as we know, so Soumya would like to highlight that here because many people are listening. So Dr. Gagandeep Singh has been working. He's a important
Yes,
member of
yes.
the Indian Academy of Neurology. So he has been working on
Absolutely,
this.
absolutely. Dr.
Yeah.
Gagandeep, and now I'd also like to highlight that Dr. We have a advocacy group in the Indian Academy of Neurology, which is going to take up the challenges of patient education at various levels of the society, and especially at the grassroots level. We will be having some regional moderators who will coordinate all these activities, and for that already sir has formed a committee at the national level and even at the regional levels, so they will monitor all these social activities which are going to occur. And I think our best example is Ujjwal, who has been propagating all these programs of awareness, and hopefully it reaches out to the people not only of Ranchi or Jharkhand but also to others in Eastern India.
Yes, very rightly said. Actually, as Sunil sir also pointed out, in Jharkhand, lots of illiteracy and lots of myths are there. Still, there people are on those kind of Chandramasi and Amavasya. So everyone who comes down is talking about Amavasya and epilepsy. So so that these myths.
So that is a very nice point actually. That this catamenial epilepsy, there are three phases actually. That is the premenstrual, the ovulatory, and the luteal phase. So according to the moon cycles, actually the
Exactly.
seizures go up.
That is what. So that is what it.
Right. Ujjwal, you are mute.
If any panelists amongst panelists or even among the attendees, if we want, the attendees can type their question and panelists can ask directly. If anyone has, please, because Dr. Surinder is just about to join, who has the next talk, so we can have the questions with Dr. Soumya, because it was really very nice talk. He has covered all the aspects, and this is the most important thing actually. Because when we talk of epilepsy and awareness, so I gave this talk to him. I know he will be the best person to elaborate on this. Anyone, if any questions?
May I ask a question?
Yeah. So here we have Dipankar. He is Dipankar Chaudhary. Mr. Dipankar Chaudhary is a young IS from Jharkhand, and he is a quite energetic person. And so I invited him on this platform. Yeah, Dipankar, carry on, please. Yeah.
Thank you, sir. Thank you, sir. Sir, it was mentioned in the very beginning that seizures don't always mean epilepsy. So there could be other causes of seizures also, especially in small kids. How do we know that what is causing this seizure? And how do we propagate this idea that seizures don't always mean epilepsy? And I have a follow-up question also. So with the advancement of neurosurgery, is there a surgical option available to treat epilepsy?
And that's very important question from administrator actually. So I'll answer that question. So epilepsy, see, when we talk of seizure, basically it's an abnormal electrical individuals, like abnormal electrical impulse that propagates from the brain. But there are something called called paroxysmal non-epileptic seizures. So then we call those things as a seizure also. So now that's a matter of research. Sometimes earlier we used to call it as hysteria or something like psychogenic, these kind of things. But now a totally different term like paroxysmal non-epileptic seizure has also emerged, and those seizures are exactly not epileptic. So we prove it by video EEG. So we do a EEG on that person or child, whatever. Just last week we had a patient who had intractable seizure, was taking around 6 to 7 anti-epileptic drugs. So we put this child on a video EEG, continuous video EEG monitoring. So whenever that child would have a seizure, so we will monitor the EEG. So we will time that actually. So when the patient has some movement, so sometimes it's functional, as we say, or psychogenic sometimes seizure. So there are many patients who comes to us. When we sit in neurology, OPD, busy neurology, OPD, we do see these kind of patients. But when we do this, timed video EEG, so if this suppose seizure comes at 11:01, so at 11:01, what was the EEG? So if seizure is there are epileptic discharges, then it's proven that yes, this is a original, this is a seizure. But sometimes it's a PNES, so paroxysmal non-epileptic seizures. So those are it's the matter is debatable. What are the causes of that? We are still research is on. We think it's as a neurologist, we think it is psychogenic, but there is lots of research that is going on that why these things actually occur. And then we offer them, cognitive behavior therapy, behavioral therapy, and sometimes anti some depressants and the kind of things, SSRIs, as we say. So selective serotonin reuptake inhibitors. So that is the answer of your first question. And second question, what was the second question?
So I wanted to know, with the advancement of neurosurgeries, surgery an option for epilepsy?
Yeah, that's a very important. So again, the answer for this would be like surgery. When we talk of surgery, it's a very, so we have to first see that what is the focus of that. So we do some advanced tests like SPECT, sometimes PET also we do. And then there is some some cortical EEG that we do. So we localize the that there should be clinical. So suppose a patient is having a movement in the hand, so it should be, so clinical, it is like it has to be on the motor area, the hand area. Then we do the MRI, so there has to be some either some tumor or some lesion out there. Then on the EEG also the same, on the same there has to be some discharge from that side. And then lastly, the thing is that when we do a SPECT and all, so there should be some metabolic problems out there. So when this electroclinico, clinico electro, radiological correlation, then we go ahead with these surgeries. But this is only a case in like maybe 10 to 15% cases actually they require surgery. It's not that when the drug is not acting, so we go for surgery. It's not like that. So first we have to really localize what is the what is the cause of that. If there is some localized thing, suppose we have a frontal lobe tumor that is continuously causing some focal seizures, so yes, we can do some surgery for that. Sometimes mesial temporal lobe sclerosis is a very it would be difficult for people who are not there. So mesial temporal lobe sclerosis, so there's one area, mesial temporal lobe. So if there seizures arise from that area, so we try to resect that area or do some other surgery on that area. But for that we have to be really sure that yes, this is the area only that is causing the seizure. And then because if we just go and do surgery, what we are going to do? Sometimes we also do surgeries for refractory seizures like corpus callosectomy. Like if there is generalized seizure, so we just so there is corpus callosum is a midline structure actually. So when we remove that seizure doesn't generalize actually. So because once it arises from here, so it will propagate to the other side of the brain. So there is some corpus callosum in between to propagate the seizure to another lobe. So when we resect that corpus callosum, so then the seizure doesn't become generalized. So just basic. But the thing is that it's not well and better said than done. It's a very difficult thing when we talk of epilepsy surgery. There are many things that we take an about when before going to surgery. There are lots and lots of investigations that we do, and then only we go for a surgery where we really benefit. Dr. Somi, I'd like to comment on this.
Yes, Dipankar, yours is a very good question. Actually, seizures are difficult to identify, especially in children, because children don't tell their symptoms. So, most often we have to recognize subtle signs of seizure. Sometimes the signs are very overt, or you just see a person seizing, some motor activity is there, but sometimes just an abnormal stare of the eyes abnormal lip smacking, or abnormal chewing movements can mean seizure in a child. So, as Dr. Ujjwal has rightly pointed out, if you have a suspicion of seizure, you refer to a neurologist, where the neurologist will do a video EEG or continuous monitoring of 24 hours ambulatory EEG, and he will do some localization related MRI or functional MRI. So that way we can, but in clinical practice, most of the times what we do is, if we have a high index of suspicion of seizure in a child, we do a EEG, a baseline EEG, and we treat according to our clinical intuition, because only 30% EEGs will be positive and less than 10% of the MRIs will be positive. So that is regarding the childhood epilepsy. Yes, as Dr. Ujjwal has pointed out, less than 1 to 2% of these refractory epilepsies, or epilepsies which are pharmacoresistant, do not respond to drugs, 2, 3, 4, 5 drugs. These cases go for epilepsy surgery, because surgery again is a matter of precision. So that is pursued only in very, very high centers. It is not available at present to common public. So it's very costly affair. So right now, our neurologists we have in our armamentarium mostly drugs, and we have to ensure drugs. Now that the government is providing some free drugs, so these older anti-epileptics, some new drugs are coming up. So the patients who are actually treatment naive, they are getting the drugs. So yes, epilepsy surgery is an option. It is coming up, but now it is only restricted to very, very high centers. And all the surgeries Dr. Ujjwal has elaborated.
Thank you, Soumya. That was
Thank
so.
you. Thank you.
Yeah.
And
So now Dr. Surendra has already joined, and he's associate professor, my very dear friend, and he has been doing great job at RIMS, and he has lots and lots of interest in academic activities. He has been promoting this in Jharkhand since he has joined as a associate professor in RIMS, and he has many papers and delivered lectures in international national platform. Without wasting time, I would give the mic to Dr. Surendra.
yes, so thank you for your kind words. Actually, my this time my topic of presentation is epilepsy, children, and myths about epilepsies, and how we should educate our physicians or pediatricians regarding epilepsies. So, as already all these things have been discussed about what is epilepsy. Epilepsy is a disease of the brain characterized by an enduring predisposition to generate epileptic seizures. And as it can be diagnosed after at least 2 unprovoked seizures or after 1 unprovoked seizures, and there is a 60% chance of developing the other unprovoked seizures over the next 10 years, or when an epilepsy syndrome can be identified. So in this way, epilepsy is defined. And then coming to the now, what about epilepsy in India? About 12 million population people with there are people with epilepsy in India, and about 1/6 proportion of global burden is contributed by India. And the prevalence of epilepsy in India is about 3 to 11.9, and which increases in the younger age groups, like pediatric age group. The prevalence rises up to 22 per lakh as well. And as we know that risk factors in India are like in childhood is like febrile seizures, developmental delay, then there is head injury, family history of epilepsies, antecedent history of neonatal seizures, then there is birth by complicated deliveries. And many myths are associated across all the ages. If you have a seizure, first myth is that if you have a seizure, it means you have epilepsies. The fact is that epilepsy involves having seizures that occur repeatedly. And seizures may occur as a result of several other medical conditions, like in a case of child, there is a high fever or low blood sugar or low sodium or low calcium or low magnesium. And even after, if after the corrections of these metabolites and all, if there is still having persistent seizures, then it will be termed as epilepsy. And if the seizure don't reoccur in such conditions, it is not considered epilepsy. And as such, 10% of people have a chance of developing a seizure during their lifetime, at any age of their lifetime. Then the myth is that epilepsy occurs due to bhoot pret. But it is not occurs due to bhoot pret. It is a disorder of the brain, and which is caused by abnormal hypersynchronic electrical discharges, and it has multiple causes during childhood. Like the most common cause is genetic, that is idiopathic, which is and cause is unknown, but it is presumed to be genetic, 70 to 80%. And there are certain secondary causes like cerebral degenesis or malformation, cerebral vascular occlusion, cerebral damage, like congenital infections, drugs, alcohol, then HIE, birth trauma, then CNS infections, Kernicterus trauma, tumors, then neurodegenerative disorders, neurocutaneous syndromes. Then other myth is that all seizures involve convulsions. Fact that is GTCS is the only type which is characterized by tonic-clonic activities of the upper or lower limbs, or both involving the upper limbs and lower limbs, along with the face and deviation of neck and tongue bite and all. So seizures of different locations have different simiologies, and these things we need to teach our pediatric residents and medicine residents, physicians, that there are different locations and there are different semiologies for that localizations. Like in the frontal localization, there is a rapid onset and rapid offset of events, and that is a tonic-clonic activism, which may be preceded by some automatisms and sometimes also by change in behavior. And they occur very rapidly, and within seconds or within a minute, they subside. So it should not be confused with this. Sometimes most common cause of pseudo seizure mimicker is a frontal lobe seizure. So we have to keep in mind that it is a frontal lobe seizure and not a psychogenic seizure. Then the other one is the temporal lobe seizure. Many a times we get consultations from gastroenterologists, like the child is complaining of vague abdominal pain and like butterfly-like sensation in the stomach, and the sensation goes up to from the esophagus up to the throat, and then the child loses consciousness, and after 1 or 2 or 3 minutes, child regains consciousness and he becomes as he was or she was before the event. So he consults many gastroenterologists in the process, and then comes to us, and then we find that it is nothing but abdominal aura, which is a very common aura, and that is followed by loss of contact with the environment. Then the other auras, like we all know as a neurologist, but we should teach our residents and all, like there is gustatory, the hallucinations, like the burning of tires like smell or electric wires like smell, and nobody else is having that smell, and the child is having that smell. So it can be seen in some temporal lobe tumors and all. And then sometimes the child may become fearful, and his faces become fearful, and he's not able to tell anything. And so we think that as a common people thinks that the child has become fearful just because of some day-to-day events. But we have to be very cautious and look for temporal lobe seizures in those children. Then there is Deja Vu Phenomenon, as we are all acquainted with that, and also Shawmai phenomenon, which is the contradictory part of this Deja Vu phenomenon, in which in the temporary Deja Vu phenomenon, we think that we have come to that place which we have the unfamiliar place which we are, but still we find that this place I have visited before. So this type of sometimes parents may find that my child thinks that he from the previous birth he has some connection with this place. So that is not the case. And so, hello, am I audible?
Yes,
Hello.
yes, you are. Yes, yes.
Okay. So that is about deja vu phenomenon. And the other one is the Jamaica Vu phenomenon. It is similar like that the child is seeing her mother, and he knows that he or she is her mother, but still he finds that no, she looks like my mother, but she's not my mother. So the familiar faces he is seeing, but he is thinking that she or she is unfamiliar to him or her. So that is the Jamaica phenomenon. Then there are certain seizures in which they're like Panitopoulos syndromes. In this syndromes rarely visits the neurologist, because they are basically dealt up by the most of them by the pediatricians. And as this occur once or twice in their lifetime, sometimes this kind of autonomic seizures like this Panitopoulos syndrome can be very drastic and can lead to sudden cardiac death as well. In this, the seizures, autonomic seizures, which are benign in nature, the seizures occurs with the stretch of the child may try to, there is a rectal itch, so he will feel like that there is a retching in the heart, and then followed by the sensation of vomiting, and then his face will become pale and the cyanosed, and his eyes pupils will dilate and then constrict, and the patient might lose contact with the environment, and there can be subtle changes like in the movement of eyes to the either direction, and the patient will then go to sleep. And after going to the sleep, and when he wakes up again, all the seizures, all the things have gone. The child is now again fit. So the most of the time, parents as well as pediatrician as well as general physicians will discard it as a simple gastrointestinal disturbance, and that children. The best part is that very rarely comes to the neurologist, and when they come to the neurologist, we treat them with some anti-epileptic drugs, and it never occurs in their lifetime, and up till they gain the age of 14 or 16 years, it goes away. Then there are the different types of seizures like gelastic seizures, in which caused by the hypothalamic hematoma, in which there is an inappropriate laughter in the child. And then there are some parietal lobe seizures which can be seen as a marching sensory phenomenon, or some dysesthesias or paresthesias, which can be told by the elderly child. And then there are some occipital lobe seizures, that gustave occipital lobe seizures, which are benign in natures. And this occipital lobe seizures has to be confused with migraine. So to differentiate them from migraine, we need to what are those hallucinations which or auras which they are seeing, that is visual auras which they are feeling, experiencing. So in the cases of the migraine, all the things are black and white. But in the case of occipital lobe aura, all the things are colorful. That is in the elementary visual hallucinations, all the things are that colored halos, colored blue, green, red halos he will see in the either side of the their visual fields. And then that is followed by headache. So headache is a very prominent feature in the occipital lobe migraine, and which needs to be differentiated from the migraine type headaches. Then coming to the other, then there are other seizures types also, like absence seizures, that like childhood absence epilepsies, which leads a child in a otherwise normal and intelligent child to behave like he is not able to cope up with his academic activities. So absent seizures occurring 10 to 20 to 40 to even to 100 times per day, and which is controlled by anti-epileptic drugs. Then other like myoclonic seizures, then atonic seizures, and as I already mentioned, that autonomic seizures. So all the seizures involve convulsions is not a truth. It is in fact, the fact is that seizures is considered by for many types, and the GTCS is only one type. And the best part is that most of the common type of seizure is GTCS. Around more than half of the seizures are GTCS in nature. Now, coming to the other myth, that epilepsy treatments don't work. But that is not the case. 2/3 of people, and so that's why in our people of Jharkhand and all other states of India as well, they seek for the help from the quacks and Ayurvedic or that is or homeopathic treatment, and those treatment don't help them much, and but they are very skeptical of this allopathic treatment. And but the truth is that 2/3 of people with epilepsy can completely control their seizures with the right kind of medication with the right dose. And for the another 1/3, there are other treatments which already have been told by Dr. Ujjwal and Dr. Soumya Darshan. Like before going for surgery, I would like to tell that there are other treatment options like dietary options, like ketogenic diets, then vagal nerve stimulations. And if at all it is not helping, then we can go for these surgeries like corpus callosotomy or hemispherotomy or resection of the tumors, or let's say so this kind of surgery we can go for. And if that the location is non-eloquent one, then the surgery is going to be beneficial more. And if it is present in an eloquent area, then the surgery may harm more than doing good. So it has to be decided by the team of epilepsy surgery, then physician, and all the group of the members. Now coming to the other part, that other some people think, many people like think like you can't die from epilepsy. It occurs, and then again he will become all right. That is the case with most of the time, but you can't say that it is not a very serious condition. It is a very serious condition, and individuals die from seizures if they develop status epilepticus. That if the patient's seizures patient do not become well after 5 minutes of this seizure, then we have to be very careful, and we have to give them rectal diazepam, or in the intranasal, that is where we can give them midazolam and all. And if still they are not controlled, then they should visit the hospital. Then the other myths are like people with epilepsy should not have jobs with responsibilities and stress. But the fact is that epilepsy is not a discriminatory condition, and people of all walks of life and at all ages experience seizures, and people with seizure disorders can have successful careers in many different professions. And there have been most of the seizures in which there are benign seizures, they go well. Like my younger brother was having 1 or 2 episodes of seizure in his childhood, but he fared well. He was treated by Dr. K.K. Sinha sir, and now he is a founder, a member of his office. That is, he is a software engineer and is doing good than us, all of us. So that is a part that many times, and there are many famous people as well, like United States President Theodore Roosevelt, and there are musicians like Elton John, rapper, and Donny Glover, actors. So all these, they suffer from epilepsy at their younger age and all, and they have done tremendous work in their fields, respected fields. Then the other is like people with epilepsies are mentally ill or intellectually or developmentally disabled. So as told that there are few conditions that like epileptic encephalopathies, in which there is definitely the patients become intellectually disabled and all, like Lennox-Gastaut syndrome or West syndromes in there, and the Otahara syndrome, or other syndromes like this Landau-Kleffner syndrome. See, all these epileptic encephalopathies, definitely, but the good Dravet syndrome and all. So the good part is that they occur very rarely, and most of the time, in the childhood, the most of the children have epilepsies which are benign in nature, and they go as their brain matures over time. Then other is that the serious myth is that epilepsy is contagious. No, epilepsy is not contagious. You are not able to catch epilepsy from another person. And it is a disorder of the brain, as I've already told. And other myth is that during a seizure, the person is in pain. During a seizure, a person is unconscious and does not experience any pain. However, some people may have muscle aches and can be tired after a prolonged seizure. So one is that one more important myth is that someone is having a seizure, you should put something into their mouth to prevent them from choking. So never put anything in a person's mouth who is having a seizure, and this would end up hurting the person more. Instead, gently roll the person onto one side and put something soft under his or her head and wait by their side until they become conscious. Another myth is that you should restrain someone having a seizure. Never hold down a person during a seizure. Holding someone down can cause a bone or muscular injury. Instead, make sure the surrounding area is clear of objects and their head is patted with something soft. Then other is that video games or strobe lights will trigger seizures. Only 3% of people with epilepsy have visual triggers. And this is a very rare phenomenon. Yes, I am winding it fast. So only for my physician friends and for pediatric friends. So in the history taking part, we have to be very cautious about the semiologies, then how did it last, frequency, time of the day, any loss of consciousness was present or not, any tongue biting was there or not, and what did you do for the child at that time, and postictal, how much there was the loss of consciousness. And then the other thing is that whether there was any infection during pregnancy, like torch infection or birth asphyxia, birth trauma, neonatal jaundice, or any history of in the childhood, like post-encephalitis, or he was a case of meningitis, or he had suffered from head injury, or he had any history of pica or not. Then other histories like age at first, when the first stage of child seizures occurred, whether there were history of any febrile seizures or not, and what drug history was there, how many drugs he was on, and other things like how many hospitalizations, and all about any family history of any inborn illness of metabolism, or any inborn illness of metabolism currently diagnosed or not. So all these things in the histories and the physical examination, we have to look for the presence of neurocutaneous markers, consciousness levels, postures, deformities, whether there is a head size dysmorphism or shape, cranial nerves examination, then gait and spine. And we have to neurocutaneous signs like ephemeral spots, then neurofibroma, adenoma, sebaceum, and all. Now, about all these things, now coming to the conclusions, epilepsy occurs across all ages and individuals, most commonly involves pediatric age group and elderly. Unfortunately, epilepsy is associated with various myths. Scientific knowledge has helped in busting several myths. Different epilepsies can be identified by history taking, evaluation, and investigations. Pathophysiology of various epilepsies is still not known and generating an area of interest to researchers and clinicians. Thank you for your kind attention.
Thank you, Dr. Surendra. It was indeed a very lucid talk about myths, epilepsy and related myths, especially in children. And you have covered, I think, all the topics. We are already running late, so we'll take the questions later. So just straight away we move on to the next talk. So we have a public health specialist, Dr. Chitranjan Rai, we have with us. So he'll be talking on public health issues, and there's some how to summarize that what should be the take home message for all of us when we talk of public health and epilepsy. Meanwhile, if there is any question, we can take Like,
Yeah, Dr. Ujjwal.
sir.
Hello.
Sir,
Yeah.
good evening, sir. Good evening, sir.
Dinesh, first of all, I congratulate you
Sir,
to do the doctors not only examine the patient and treat this, but they have to maintain that social responsibility, because epilepsy, this is not a clinical disorder, but also it has some social burden level. Before that, I want to ask Dr. Nayak one question. Dr.
Nayak, are you
Darshan
there?
Nayak.
Yes,
Doctor,
sir.
Yeah,
Good evening.
Dr. Nayak, one thing I'm just asking you. Just
Sir.
one lady that is the one a non-epilepsy patient on anti-epileptic drugs. Suppose you do two lady, one is on sodium valproate and others is on levetiracetam. They one have come with that I am valproate, that I am, sir, I am non-epilepsy. I am on medicine sodium valproate, but I'm 3 months old pregnant. What to do? This is in the hospital in chamber. We are facing this problem from this young lady, and one is that I am an epilepsy. I want to be the pregnant. Now what I shall do? This thing, guide me. That is the thing. And during this, so much improvement of the science. There is a revolutions in this field, especially neuro radiological field and genetic field, and everyone, especially the educated people, they are very much conscious regarding the genetic part of the epilepsy. But in this case, what to do is the.
Thank you, sir. It's a very pertinent questions which we doctors face in our day-to-day practice. I say your case comes after 3 months that she's already on
Yeah,
valproate. We have faced situations
yeah,
where the patient has come to delivery and she's already on 2 or 3 older drugs like valproate, phenytoin, and carbamazepine, where we can do actually nothing than just deliver her baby and pray to God that the baby is safe and sound. But if a patient lands up at 3 months with sodium valproate, so there are three things which we have to note. Already, the stage of formation of the organogenesis is almost over. It's almost 12 weeks. So we try to titrate the dose of valproate. Most studies have shown that a 200 milligram twice daily dose of valproate is sufficient to control seizures. As such, 33% of the seizure women have decreased frequency of seizures. So we come down to a maintenance dose of 200 twice daily and supplement with folic acid. And at best, what we can do is we can do a serial monitoring on ultrasound to look for congenital anomalies. And since the woman has presented at 12 weeks, we have 8 weeks in our hand if any congenital anomaly is detected to abort the fetus, medically abort the fetus. But if the woman has a safe child, the child is safe in all respects, she can continue her pregnancy and she can continue on valproate also. The next question is switching over to levetiracetam. We do know that levetiracetam is vis-a-vis a little lower efficacy than valproate in conditions where we have generalized seizure or we have multiple seizures. So switching to levetiracetam would be a little bit dicey, because if the female develops epilepsy with levetiracetam while switching over, it would be a hazard for her fetus. So our recommendation by the experts would be to continue with valproate, but at a lower dose, and supplement with folate, go for serial monitoring. If we have a female who is planning for pregnancy, any switch, be it to levetiracetam or to lamotrigine, has to be done prior to pregnancy, at least 12 weeks prior to pregnancy, so that any indication of seizure is best dealt with by increasing the dose. So we should have at least 12 weeks in our hand before we ask the patient to get pregnant. So switching over prior to pregnancy is advisable when the patient is on older ADs like valproate, phenytoin, or carbamazepine. But if the patient has already crossed 12 or 16 weeks, the period of organogenesis, it is better to continue on her older anti-epileptic and see that she sees through her pregnancy safely without any hiccups, not to do any changes or modifications during pregnancy. So that is the dictum. And
So, sir has been actually
Thank you.
just one line I'd like to say here, Dr. Somaya. Sir has been working in this field, pregnancy and epilepsy, since last around 10 years, and he has been guiding many theses also on this.
absolutely,
And this
absolutely.
question he has raised this question. It's a very pertinent question, and we all face this question in our daily practice. So, and you have
Absolutely.
answered it absolutely. I mean, it's wonderfully. So,
Yeah.
sir. So we
Thank
just
you,
go
sir.
to the last speaker, and then we will have a panel discussion of for. So we have Professor Chitranjan Roy, who is eminent public health person of Eastern India, and without wasting time, I would like him to invite on the dais. He would speak on uh, epilepsy and public awareness. What should be the take home message?
Thank you, Dr. Ujjwal and his team, and especially Professor, the participants and the panelists over here. Professor, I'm glad to see Professor Ganguly over the dais, and the bureaucrats. Apart from academician, the bureaucrats are also here. So it's a good opportunity, and the disease like epilepsy, the participants, including the bureaucrats, is a major development in this field. Because when you talk about any public health program, the politician has already, the Honorable Prime Minister has already quoted this, to quote, that the government has aid in designing country health program. We have created a delivery model that fragments and dissipates energies. Most importantly, we have paid inadequate attention to the public health issues and the possibility of social and preventive medicine, unquote. So this has been quoted by the Honorable Prime Minister, and we are in a mission mode. So what we else can do with the disease, which is by and large, I can say that about 25 to 50% cases are preventable. And there we can do something as far as the primary, secondary, and tertiary prevention is concerned. So we have got 3 levels of prevention, you all know. And as far as the public health is concerned, what is public health? That you know that prolonging, preventing diseases, prolonging life, and promoting health through organized community efforts. So we are having a panel discussion. We are having a webinar. That's very nice. And I think that initially there were 25 participants. So when we say that, and if you have left, so जाने वाले तुझे प्रणाम, आने वाले तुझे प्रणाम, जो वेबिनार में बैठे हैं उन्हें प्रणाम, काल वृक्ष के नए पात पर लिख देना मेरा भी नाम. So public health, though ignored many times, but has got a very important role here to play, both in the primary, secondary, and tertiary prevention and control of the major things for which we are having this World Epilepsy Day, organized since 2015, and we have now this year theme that 50 million steps for epilepsy. Means we have, if you have got a 50 million, not 50 millions, it is, though statistically we say that there are 50 million patients, but patients are much more, because I thought that Dr. Nayak has also mentioned, so many of the presenters have mentioned including Dr. Surender has also given the data about the myths and discrimination. There we have to be very particular that the figure that is being projected globally is not the actual figure. Many cases are missed, ignored, and you know that in the state of Bihar and Jharkhand, especially, that many cases are being treated by the traditional healers. So in that situation, what is my opinion, that you all know that epilepsy is just like any other disease. It is a disease, a neurological disease, which is taking more and more, number of cases are more and more increasing, and expected to increase as the longevity is increasing. So what is that? The age factor is not limited. That previously we used to see that it is the children which are affected. Now all ages are affected, and elderly are also affected. And as we have seen from the panelists and the speakers, that the disease is curable, can be prevented also. So in that case, what we say, that the World Health Organization is also very much concerned, and in its assembly, they have requested, and they have rather suggested all members of the WHO and in this World Health Assembly to promote and to increase the national program on control of epilepsy. You know that we do have several programs, and after all, merging all the programs, we have got a national health mission. So, but we have got program for control of communicable diseases, and as we are in a epidemiological transition, we have got both, that we have got a program on non-communicable diseases, the NCDs programs, and where we have but a few years have passed, but it is not being reflected so far, that prevention and control of cancer, diabetes, and cardiovascular diseases, and a stroke. So this program is also is running, and is now is a national program, having all the PSC, where we ought to have the messages for control. Because this has not been practically organized, and it goes on in a message way, that if somebody has got diabetes, somebody has a cancer, that has to refer. And if something can be done, like health education and other things you can do, then you may do it. But I'm not going to have more and more time. But this much I can say, that the perinatal risk factors, to start with the birth of the child, the perinatal risk factors that can very easily be taken care by the cases of IGUR, intergestational growth retardation, and small for death babies, low birth babies. So Dr. Surender has just pointed out that supplementing the antenatal care, where we have to supplement the nutritional things, again the immunization, and the most important thing is traumatic, the perinatal and this intranatal trauma is again another part where we have got the injury. So injury to the brain, and that leads to epilepsy. So now we do have the institutional delivery, where we expect that these trauma should be ameliorated, but still we have got the cases of trauma. And after that, then we have got the infection. Infection is another factor which leads to, that has been told by the learned speakers. But I can say that the one thing which is your neurocysticercosis, where we can do by take care it by deworming. And apart from that, we have got bacterial meningitis and viral encephalitis, and even all these. Apart from that, we are seeing that in Jharkhand we have got a uncontrolled, not this falciparum cases. So these are all malaria itself. So what I think, even the other infections like you say that Hib, so Haemophilus influenza B. So in that condition, what we see that immunization is also very important. And if this message goes, because what need that, of course it is a topic where the importance goes to the neurologist. They have got the upper hand to understand and appreciate whether it should be classified as epilepsy or whether it is simply a seizure which will go spontaneously. But on what are the different types, we do have a very academic talks. But I think that it will be very wise and prudent if the medical officers, the persons in the surgencies are being educated about that. And then if you come to the other factors which are responsible, which can be prevented, is the trauma of the brain injuries, which is I think that the brain injuries are very common nowadays because of the high speeds and motor vehicles. So there are the other thing that with people with severe this TBI, they can also go for, and they are also reported as a stroke. And then what you see that a stroke itself is one of the cause for this epilepsy. So primary prevention that I'm talking in length, this has to be educated not only to the medical officer over there, but other persons involved in the National Health Mission. I mean the other persons. So I think that I'm taking a lot of time, but this much I can say that if you take care of these things, you will have the primary care, and then the secondary interventions, that early diagnosis and treatment, and the tertiary care where you have got disability limitation and rehabilitation. There, epilepsy requires all those things, and then we can see that it is 100% preventable, 100% curable, and patients will have normal life. There is no stigma. There should not be any stigma, and this message must go. That is, there should not be any discrimination. And WHO has come up with this theme also, that stop discriminating, give the proper care, and dare to care. Dare to care. You have to care them. You have to accept them in our society. Epileptics are not. We do have a society. In India, we have got Epileptic Society, Indian Epilepsy Society, but we don't have a national program. This is a major issue. China has got a national program. We don't have a national program. But what I see, that if any program of non-communicable diseases, because Dr. Surendra has already, or other participants, other scholars have already told that this is not a communicable disease. This is not communicated from person to person. This is not inherited as well. So what you see, that if you take care of the nutrition part, if you take care of the maternal part, we take care of the vaccination immunization part, and if you take a lot in prevent, then it will be a lot of steps in preventing the entire pandemic of epilepsy. And India, though it is a what is called developing countries, major cases are there from the low or developing country, but still we will have a better chances. So I don't think that leprosy is an issue where we should be frustrated, and this message should go कि गम की अंधेरी रात में दिल को न बेकरार कर, सुबह जरूर आएगी, सुबह का इंतजार कर. But what I wanted to say before I take leave of you, that do not discriminate. इलाही कैसी कैसी सूरतें तूने बनाई है कि हर सूरत कलेजे से लगा लेने के काबिल है. इलाही कैसी कैसी सूरतें तूने बनाई है कि हर सूरत कलेजे से लगा लेने के काबिल है. So give all love and affection, and let the person suffering from epilepsy lead a normal and beautiful life. Thank you very much. It is time for lunch.
Thank you, sir. It was
Clear.
it was a very awesome presentation, and I think we are already. So we will should switch over to panel discussion. We have all. So I think we have Dr. B.K. Pankaj, who is a senior neurophysician in Jharkhand, and we have other people out here. So I think it was a wonderful session. If you, one question actually, it was from Saurav Sarkar. So Saurav Sarkar is asking that how can we be sure about recovery? It has been almost 2 years. So now the thing is that, see, as I initially also I told you, it depends upon what you have. Basically, what is the diagnosis? Suppose a patient has juvenile myoclonic epilepsy. So we know that yes, this patient may have to take anti-epileptic drugs for long, maybe for lifetime also. So we have to understand what the cause is. Suppose a patient has a very maybe some gliomatous change which is there, or maybe some cortical malformations like pachygyria or something like that. So these are seizures which are very difficult to control. Sometimes it may take multiple drugs to control this, and patient may have to take epilepsy for drugs for very long, maybe lifetime. Again, late onset epilepsy, post stroke, post head trauma, late onset. So that may be one case where we have to take anti-epileptic for very long. So actually it depends upon what you have, what diagnosis you have, and how much extent of damage is there to the brain. Also depends upon if you have idiopathic generalized idiopathic epilepsy, or you have symptomatic epilepsy. What are the EEG patterns that you have? What is the MRI? This question is very difficult to answer just on just for it's a individual based case to case. It changes. So it's not a just generalized answer. But yes, that much I can say you that much I can tell you that epilepsy is not a disease which cannot be treatable, which cannot be controlled. So this is some disease where we can control with drug, and patients can live a very normal life. As other eminent speakers have elaborated, that many celebrities, they have this epilepsy. As far as confidentiality is concerned, uh, mm, we cannot tell you all the people who have seizure, but there I can tell you there are many eminent people who have consented to disclose this fact that we have epilepsy. And those people that we have mentioned those, about those individuals, but there are still lots and lots of them which we which do not consent for that that disclosure. So that so again there's a long list. So don't think, if you have epilepsy, don't think that it cannot be treated and how long it has to be. So the general dictum is, we tell sometimes 3 years in idiopathic cases and 5 years in symptomatic cases, but it's not a rule. Suppose we taper off the drugs and again you have seizures, so then again you have to start. So if it is like 5 years, if you have no seizure in symptomatic cases, generally it's not a rule. I mean, there are different papers again. And 3 years if you have idiopathic things. So if there is no seizure, then we can try to taper it off. But yes, if you are controlled on it, don't try to stop abruptly. Don't try to change the dose yourself, because we daily see cases of breakthrough, like the missed dose, and then patient comes to us with seizure. Can we add Dr. Surender? He's messaging. He has message. Dr. Surender, please add him as a panelist. I think he went off. Then again he has come, I think so. Add Dr. Surender as panelist, please. Yeah. Any other question or any other comment? If there is none, I would like to thank everyone. If there is, and I'd like to thank Dr. Gautam Ganguly, especially who spared so much of time, and other panelists also, other speakers also who gave their valuable time for this extraordinary session. We had lots of new knowledge there was some new knowledge for me also. So it was a mind-boggling session. It is very important for us to understand that these kind of sessions are to be done on regular basis, so that common people understand about epilepsy, common people understand about the stigmas associated with this epilepsy, and also problems faced by the patients and their relatives. So it's a whole era of public and doctor domain, like public and healthcare professionals. They have to interact in this topic. So where there is a interface between the specialists, the public health people, and the common people. They have to interact. They have to be a common interface where they understand that what's the problem. And I think everyone has done their job wonderfully. So so with this, I think I'll take leave. If you have any other questions, anyone has any other questions?
Hello. Hello.
Sir, yes.
I, Dr. B.K. Pankaj.
Sir,
Yes.
Can you just
good evening, sir.
Good evening.
Sir, can you like, your video is off. If you'd like to on your video, that will be great, sir.
Start my video.
Yeah.
Yes, Dr. Ujjwal. So,
sir, thank you, sir.
Congratulations to all the participants here on this World International Epilepsy Day. Rather, for neurologists, it is bread and butter.
Sir.
And there is a lot of new things have come in this type of epilepsy, because physicians, gynecologists, in my view, and pediatricians, they all can refer the difficult cases to the neurologist. But as my guru in MBBS days, I was very much happy to see Dr. Chittaranjan Rai and Dr. Gautam Ganguly also at Bangalore Institute of Neurology. So we had some good time there. And it is good to mix all the preventive things with the community medicine, along with the implementation by the bureaucrats, because many of the things you have to approve from them. You cannot do some of the programs you want, budgets. So it is a mixture of all the neurologists and bureaucrats and preventive things. So that I like much. And I will congratulate Dr. Ujjwal and our respected Dr. Gautam Ganguly, sir, to organize this type of webinar that helped us learning many things. And awareness is the main issue of epilepsy. Even I see patients which due to poverty is on desi medication and even don't buy Epsolin, the primitive drugs. So new drugs, usually what I see, the old physicians, either MBBS, MD, they still writing Gardinal and the Grain tablet. And many of the people are taking it for long years. And we know, we as a neurologist, don't like those drugs now. Cost factor is the another thing for new drugs, but we like to introduce the new drugs which are safe, which are just well controlling the bad epilepsies, genetic epilepsies, and people who are not taking in adequate doses and suboptimal thing, 100 milligram taking for epilepsy for long. So they have to be aware that they have, if they are these are not controlled, so you have to go to a specialist. And even specialists also have some 20 to 30% of the patients are refractory epilepsy, and a lot of works are going on in Eastern India, in AIMS, in South, the Tiruvananthapuram. So that surgery in epilepsy. So in Eastern India, many of the patients are not aware that it can be cured by surgery also. Like MTLS, that is has a very, very good response by surgery. So we all are knowing this. And but still video EEG is not so frequently used by the neurologist, which are not working not associated with the institution or on some big corporate hospitals. And this is a teamwork, like psychologist, neurologist, neurosurgeon, like in AIMS, Dr. Manjari and her husband, Dr. Sarath, they are also very keen to have surgery. In Sri Chitra also. So we should be aware of ourselves also. We should be referred that type of patients to them also. And many of the time patients also don't want, because they ask that after surgery, we will be cured. So again, that time we cannot tell them that 100% your medicine will be stopped. So these are some issues that I wanted to share. And
very important issues, sir. Very important issues you have highlighted.
On a concluding note, I would like to thank Dr. B.K. Pankaj, sir, for such a elucidating presentation of the same.
Yes.
And I would like to tell that in the near future, we are going to start our DM program in neurology in our state, first time. Most likely this year or the next year. We have already applied for that in the NMC, and most likely we will get approval, because we also have two young neurologists with us. Which are the assistant professors, Dr. Govind and Dr. Rupesh Prasad, with us, and along with Director Sir Dr. Kameshwar Prasad, sir. So in the very recent time, we will be having DM program in Jharkhand as well. And I would like to highlight also some points regarding in the comment section, like apart from EEG, we should also do ECG in these patients and childhood patients, because many a times these patients are having recurrent syncopal events along with this seizure events, and like long QT syndrome, and that can be missed, and that can lead to the loss of life of the patients. And also some patients like autoimmune encephalitis, who are having refractory seizures. So that diagnosis we also have to concern in this children as well as young adults. And because these tests are very costly, we are sending them regularly to NIMHANS, Bangalore. And those tests are, in fact, costing them 4,000 rupees in NIMHANS. But from outside, if we are sending, it is around 18,000 to 20,000. So in the selected cases of this refractory cases, we should also look in terms of this diagnosis, like autoimmune encephalitis and all. So this is also an area of concern. So thank you for your wonderful presentations, all of you. I have learned a lot from all these presentations. Thank you.
Yes. One last question that some Neeraj Sharma. So pregnant lady on valproate, well controlled, comes in 5th week of pregnancy. How to proceed? We will finish with this question.
Yeah.
So, I think yeah.
Dr. Soumya Darshan is there.
Soumya.
Yeah.
Dr. Soumya, yeah.
Yeah. Already we have reiterated, Dr. Ganguly had asked a similar question.
Yes.
So if you have a patient at 5th week of pregnancy, already started on valproate, so it is better not to do any switch if the patient's seizures are well controlled. You just monitor the pregnancy, do fetal serial scans, and try to titrate to a lower dose of valproate. The safest dose, as Dr. Radhakrishnan has pointed out in his research, is 200 milligrams twice daily. 400, maximum 600 milligram of valproate is safe. It's not that all will get congenital anomalies. Less than 10% get congenital anomalies. So continue with the same treatment if the patient is well controlled. If there is any obvious congenital anomaly, go for a medical termination.
That is absolutely correct.
Any
And
switching has to be done prior to pregnancy, not
yes,
after
Yeah.
pregnancy.
And the most important part, one more part is that very few ladies should be started on actually valproic acid. Because
Absolutely. This is a
because
very important point.
most
Actually, once a lady is of menstruating age,
childbearing age, yes.
childbearing age also, so it is impertinent that we switch her over from valproate, because valproate has a lot of issues like weight
Yeah,
gain, hirsutism,
yeah,
and
virilism and all,
PCOS. So all these things develop.
PCOS
So
and all, yes.
all doctors should be aware that once you have a girl who has crossed 13 or 14, so you should gradually switch her over to safer anti-epileptics.
yes, that is what.
Yes.
That is what yes, we do in
We
common
should
practice.
do.
Yeah.
Yeah. So
Because
from
not only that, but also about it's also about polycystic ovaries, weight gain, all those kind of
Yes,
things also.
yes,
hirsutism and all,
Yeah,
that is
hirsutism.
a
Yeah,
very
yeah,
bad things for LED.
yes, yes. So thank you very
Apart
much.
from cancer.
Thank you for patient listening. It was a wonderful session indeed, and I thought thank you everyone, including my seniors, my colleagues, that everyone came here, and including the bureaucrat, the people from bureaucracy side, Mr. Sunil Barnawal, Mr. Dipankar Chaudhary. They graced the occasion, and apart from that, we have senior people like Professor Gautam Ganguly, and Dr. B.K. Pankaj, and my other dear colleagues. Thank you very much. Good night. Thank you very much.
Good night. Thank
Good
you
night.
to all.
Good night.
Good night.
Good night.
Thank you, Joel.
Thank you, sir.
Thank you. Thank you. Thank you, sir. Thank you, sir, Doctor.
Thank you. Thank you very much.
Thank you, sir. Okay.
So Dipankar has given full time and he is still here. Young bureaucrat. तुरंत हाँ